really, really good at moderating, and we are we're very casual. So Jeffrey will ask a question, maybe to me, but if you have thoughts that you want to add to it or vice versa, that's completely fine.
Sounds good. Sounds good.
Yeah, I think we're getting pretty close. Yep, we're up. So, you know, we'll continue kind of with the casualness of the conversation. There's a couple places that I need to share it to. So we are, just so that you guys know, we are actually
Ooh, live on Facebook.
we are live. We are live.
This is my first one. I've never been on one of these, so this is great. I'm one of those people who has like I post maybe every few 6 months or so, but so I'm trying to up my social media game. So this will be good. A jump start.
It's time.
Yeah.
The nice thing is it's really just having a conversation, and it's being recorded, so it's very, as I said, very informal, which is nice.
Yeah, and I'm just so glad we got the chance to do this, because I know with our webinar, it was just, we definitely needed to have like this exact conversation. I think is the missing link, and I'm glad we're on it.
Absolutely. Jeffrey, do you record this?
I do.
Okay.
Actually, I mean I can. Normally I download it from
okay.
From but yeah.
But anyway, we would have this that we could send to Lauren to use.
That would be
definitely
great.
Yeah, I'll drop it in a Dropbox.
Our website, if you guys are game for that, we'd love to.
Of course.
Yeah, absolutely. And again, you can use it. You can put it on Facebook or however y'all want to use it.
So guys, just so that you know, we are officially live. We do have a good group already watching. I will actually monitor for you guys, just monitor the comment section so that if there are questions that come up, because I always do welcome questions. And so I'll monitor the comment section here on my phone. So if you see me look this way, I'm actually looking at my phone. And your friends at Injury Prevention are already live and watching, and they say hello.
Welcome.
Hey, make sure you guys give Lauren a big thumbs up here. Since you guys are Injury Prevention, since you're watching right now, give Lauren a big thumbs up.
Yeah, hopefully I do y'all proud. We'll see.
If you don't, they'll just ban you from all future live conversations. So we're going to actually get started in we got a good group already joining in, so we'll get started when my clock says 10:35. Just to give you guys a reference point, it's 10:34, and so I'll cue you guys in, and we'll jump on in and get started. So I'm excited.
Good, I know.
This is literally probably, we talk about what's the one thing that you want to carry forward post COVID. This is probably the thing. Because it allows us to have so many more expansive conversations than we would have been able to, like normally we would have asked you to come to the shelter and fill out this form.
I would love to do that. That's the thing. I know, but
we can do that. You can still come to the shelter.
At some point,
yeah. So when we get through it, you can definitely come. It's just, it was so much harder of a setup, right? Like I had to set up I'm using 2 phones so we can do Facebook and Instagram. And this is just so much cleaner. And then we were worried about what's the audio sound like and what's that feel like. Sure. And so now it's like, boom, as long as all our guests have good Wi-Fi, right? We're good to go.
Definitely. I can't, at some point though, I can't wait to come and visit. And,
of course.
It's been a long time that I've known and haven't fully connected, so I can't wait to, check out your place and check out the shelter and see what other things I can learn more about. Cause it's always good for me, cause then I get to kind of take that information back to our practitioners and hopefully we'll be able to sort of bridge that gap a little bit better. Cause I know there's a lot of folks that really are craving that information and being able to, and just see it with your own eyes is just, it's, pictures 1,000 words. So
exactly.
And that's interesting. I don't know. I mean, we'd have to continue to think about this and talk about it. If there was a way that we could even kind of do a focus group of survivors that we've worked with some ER doctors to kind of talk about what their experience was, how it was good, how it was difficult, the things, if they go to the ER, that they would really like to see be a part of the care that's provided to them.
Absolutely. I think that would be wonderful. Yeah, we would.
We're bridging gaps. I love it. And that's what we said we wanted to talk about today.
Yep.
So, hey, it's 10:36. I am 1 minute late. It's all right. Pre-show conversation is always amazing. So I never I never like want to pause the pre-show conversation. But good morning, everybody. My name is Jeff Brown. If you don't know me by now, you've missed probably 20 Facebook Lives where I've hosted them all. But I'm the VP of Development and Marketing for Partnership Against Domestic Violence. You probably just heard me say this is the one thing out of all the things that we've done kind of in COVID that I can't wait to carry forward. And that's just bringing you guys awesome content from a platform that you guys know and love, which is Facebook Live. And so today I'm joined by Nancy Friauf, and we'll give her a second to introduce herself. But first, I want Miss Lauren to take a second, introduce yourself. Who are you? What do you do? And what brought you today?
All right, guys. So I'm super thrilled to be here. So thank you guys so much for inviting me. I'm Dr. Lauren Hudak. So I am first and foremost, I like to think of myself as a clinician. So I'm an ER doctor that works at Grady. So I do Wednesday, Thursday, Friday overnights. So I see lots of interesting things. Half the week I'm nights and half the week I'm days. So you're catching me on my day end. And then I'm also the assistant director for iPrice, which is the Injury Prevention Research Center at Emory. And I'm happy to talk more about that once we get to talking about iPrice, but I'm thrilled to be here and I'm very happy to connect with you all.
Awesome. So Nancy, who are you and what do you do?
So I am the president and CEO for Partnership Against Domestic Violence. And what that means is basically I have the great honor and privilege of kind of overseeing all the programs and services and outreach that we do and get to work with an amazing group of staff.
Awesome. Well, Lauren, you were like 2 seconds on like teetering on rule number 1 for me, which is don't answer the question before I ask it.
I knew you were going to ask, so I might as well, it's like, should I just go? I just go.
No, you have to let me, I'm only here to host, right? Like I am not an expert in injury prevention. I'm quasi-expert on domestic violence by now through osmosis. So you guys have to let me have a space in this conversation. Let me host, let me ask some questions. But first question right off the bat is what does iPrice do? What is the Injury Prevention Center at Emory?
So iPrice is it's been around for a while. We've had a couple of different names. So before we were the Injury ECIC, so the Injury Control, the ECIC was the original funded and CDC center. But now in 2015, we rebranded and it's the Injury Prevention Research Center at Emory. So it does a lot of things. So it's hard to kind of distill it down into one thing, but I'll do my best. We bring together multidisciplinary stakeholders for injury and violence prevention and try to use data to help prevent injury and violence. And most importantly in Georgia, but also in all the Southeast. So we do that 3 ways. The first way is for research. That's in our title. That's what we care about. We're data-driven people. So we try to use the public health approach to injury and violence prevention. And research tends to be the first aim that we focus on. So we support and conduct research that translates effective injury prevention projects, other clinical and also community group work out and into the community. And so we try to get our research out there. The second way is actually through educational opportunities. So we try to support our researchers, our practitioners, and our students involved in our center to learn more about injury and violence prevention and how their work can translate into effective prevention strategies. And then the third is outreach. So like this kind of thing where we want to get the word out about effective policies and practices that are happening and how we can get our stakeholders' work out into the community. I guess the thing I like the most about our center though is how, using that data-driven approach, we actually found the top killers in terms of injury and violence and put that into our task forces. So we have 5 main task forces that work to kind of operationalize our mission. And so that's transportation safety. So people die by car crashes, they die by overdoses, violence. And so those are 3 of our task forces. And then we also focus on traumatic brain injury and falls. So that's kind of what we do in a nutshell. It's the 3 missions of research, education, and outreach, and operationalized by our task forces. And then our CDC supports us, and we're one of the funded injury centers just this past year. So we're thrilled. Wow. Yeah, and I definitely drink the iPrice Kool-Aid. I've been involved ever since. And I'm thrilled to be taking on the new assistant director position this year. So Yeah.
That's awesome. Actually, one of the questions that I didn't send you, but I do have a follow-up is like, what led you to join? I mean, you know, because like when I hear you talk, man, like you are a doctor by night in the busy times. So like, what was it that said, yep, I'm going to raise my hand. I'm going to take on this role and I'm going to go over
So,
there.
you know what's funny? Because my dad is actually a OBGYN up at Northside Hospital. So for the longest time, I thought I was going to be an OB-GYN. But then I took violence as a public health problem during my my public health year, where I was getting a public health degree. And I fell in love with injury and violence prevention. Like, it really is one of those things where you see people catastrophically injured, like I do at work. And I want to think of a way to help prevent that from coming in the door. How do I help this from even happening? You know, so I can not want to like create less business for myself, but I do. Like, I want to make sure people, people are safe. And I think injury and violence prevention is just such an interesting way that people don't think about it that way. You know, that they think of car crashes as like accidental, like there's nothing you can really do to prevent accidents, but we don't think of it that way in injury prevention. In injury prevention, they're intentional, unintentional. There's ways you can prevent injuries even if you don't think that you can. And so I've found the the public health application of some of this just to be fascinating. And so that's how I kind of fell into this work and emergency medicine. I fell in love with it after that, because the Deb Howery was the instructor of that course, and she's one of the she's now runs the CDC National Center. And and I saw how she blended that clinical work so well with public health, and I loved that. So that's how I kind of fell into it.
That's awesome. Nancy,
let me just
I was gonna, go ahead, jump in here.
Let me just add something really quickly. I love hearing you talk about what you see every day, and the trauma and how devastating that is, and then wanting to do research and help create policy. That means that you don't have to see that, and that's exactly kind of what we do at PADV. Our mission is to end the crime of intimate partner violence and empower survivors. And so our shelters are kind of like your emergency room, and our legal advocacy in the courts. Like that's the emergency, that's the front door, that's when people are in crisis. And so, we have to be there and do those services. And then our community outreach, our community education, our teen dating violence program, those are all the things that are partnering with partners such as you and other partners, is the way that we try to create that public policy and that knowledge and that education, right, so that violence never has to happen in the first place. Absolutely. So it's really interesting to hear the work happening, and the goals of the work is different, but the goals of the work are exactly the same.
And it's so analogous. It's like the two of us doing the same work. And that's why I love this, because seeing what you do is so much of what we do, and how we can sort of share that burden together to help sort of, to help prevent this, and be able to, because some of the resources we have are different than what you have. And so being able to know what that is, so we can help connect those dots for our patients. And yeah.
You know what was funny, Nancy, is you jumped in there with the exact question that I was about to ask you.
So you can just sign off, and Laura and I can just. I know you love to host.
No. I was going to make the point that I was going to make the point that it's funny because you can tell we've done this together way too many times. Because literally I was about to ask you, how does it feel hearing somebody connect the injury prevention sides? And so this is amazing, and I appreciate it. Let's, Lauren, I'm going to jump in here with another question, and this one is about COVID. And so, how has COVID changed your thinking about injury prevention in emergency medicine?
And it's so tough to see that. I've heard, and you hear anecdotally, it's the times are a little bit behind the data, so we don't have exact figures and numbers to kind of present. But what we're experiencing as practitioners is absolutely an increase in violent related injuries. So the trauma centers on Fridays and Saturdays are just off the chain. So tons of patients coming in. In terms of why I think that is, it's, that social isolation I think people are feeling. It's especially with intimate partner violence and domestic violence. I think it's something that's amplifying it. We had our injury center hosted a webinar about this, where we had two of our researchers and one of our clinicians, talk about this problem from their point of view. And it truly does seem to be an issue. Like, people feeling isolated and formally or fully sort of engulfed in this in these toxic relationships, and we're seeing more injuries and more people presenting to the emergency department. So I think from that standpoint, yes, it's absolutely impacting our community and our patients. Another thing too is we also hosted a webinar on mental health issues and access to mental health care, and during the COVID pandemic. And I think really seeing people having the despair and issues with their mental health, not being able to connect to services due to lockdown measures. So that mental health issue kind of amplifies some of our other problems we're seeing in terms of chronic diseases flaring up. So there's a lot that's happening because of COVID. I think it's going to take years to dust off all the data to really see what the actual impact is. But it's something we absolutely are seeing seeing a difference and seeing an increase, especially in violent related injuries.
And I would
go ahead,
agree.
Nancy.
I'm sorry. I would agree. When COVID first hit, we actually saw a decrease in the calls to our crisis line and the requests for shelter, but that didn't surprise us, again, because if you're socially isolated with your abuser, it's very difficult to reach out for help. But as things started to open up again, we definitely saw an increase in shelter requests and calls to the crisis line. And unfortunately, we've seen an increase in the severity of the violence that is happening. I think again, stress doesn't cause domestic violence. We're all stressed, and most of us are not choosing to deal with it by becoming violent with someone that we love. But for those that choose violence as a way to deal with their stress, I think the stress level has increased so much that violence is also increasing.
This is a very interesting conversation.
It was like that with us too. Oh, sorry, Jeff.
No. Go ahead, Lauren.
Increased volumes at first. I think people were scared to come to the ED at first, and then so there was low volumes for a couple weeks. But now I'd say since probably end of May, things have just taken off. So we definitely are having increased volumes, just like you're seeing.
So Lauren, are you also seeing an increase in the severity of the violence that's presenting in the ER?
We are, it's again, anecdotally. So I
definitely
feel like it is, and I hate to be one of those practitioners because we're data driven all the way. So when I don't have my data behind to tell me, I get real anxious. But I mean, I've especially what you mentioned, Nancy, about severity of violence. I took care of my first. I'd shared this with Jeff before, but how I had an intimate partner violence patient come in one week, and I thought all the right things for that patient. Tried to connect to services, tried to get TPO filing, tried to do everything, but the patient was like, you know what, I'm just not ready. And, and then the next week came in and was killed by their partner. So it's, so we see it. And that was the first time. And I feel like I'd failed that patient, even though we do everything we can to try to give autonomy back to our patients and help them make decisions for themselves. But it's sometimes we aren't successful, and that's hard to deal with. And during the COVID times, this is the first time I've ever had that happen. And so personally, it feels like it's very, that the severity seems more. So I can't, a few months from now, when we can get some of this data, I'd love to be able to present and dust it off with you all to really kind of, put data behind the things that we're feeling. But it's been hard.
Yeah, I think that's, sorry, Jeffrey, but I think that's, what you experience is certainly one of, I hear the similarities in the way that we do this work, but do it differently. And what we face doing this work is certainly for our staff when they've had someone come into the shelter, or they've had someone seek or even inquire about seeking a TPO, and then that person chooses to go back. There can be that sense of, oh my God, I should have done more. I should have been doing more. One of the things that we talk about so much when we do training and when we do community education is it is extremely difficult to care about someone who is experiencing intimate partner violence, because you want to intervene and you want to help and you want to make it end and you want to make them safe. And the reality is it's their life and their choice. And
it's so true.
And you can't do that. And you have to accept that. And it is very, very difficult to accept that. But that's one of the ongoing challenges and reality of our work.
And us too, we teach people that way. And sorry, Jeff. I know we
go ahead.
Try to teach people to help, not re-victimize our patients by taking those decisions from them. Like, I'm not going to tell you what to do, and I'm not going to, you know, but I'm going to give you information to help you realize how worried I am about you, how scary this is, you know. And so we try our best to help people make their informed decisions so that they kind of know what they're getting into. But again, yeah, oftentimes, like you said, or not often, I hopefully say rarely,
Mhm.
something like that happens where you can't help, and then they, you know, you do see fatalities, which is, it's horrible. Yeah. And so I think it helps reaffirm my passion for the work, helps me really want to, you know, really want to help learn more and help connect with you all, even because I think there's, you know, every time we try to help somebody, there's a chance that this wouldn't happen. And so I think being able to have as much in our arsenal, I guess you could say, of resources to help these people is amazing. And so that's why I'm so happy to be able to have this conversation with you all.
Great.
Lauren, I think that's where I was going to go with the question was in that scenario or in others that you've dealt with in intimate partner violence wise, was there something that you wish you had access to
Yes.
that you did, right? And I say that only because I think we can't begin to work towards that more perfect, if there is a such thing, is if we don't really have the conversation around what does that look like. So is there something that you wish you had that you didn't in that moment?
Absolutely. And you know, I've talked to a couple of different groups about the possibility of having sort of a real human come in that's like a warm handoff, that like I can say, hey, you know, we do have our social workers who are wonderful, and they are tireless, you know, workers towards improving the lives of our patients. But a lot of times they have so many different, you know, skill sets they have to be masters of. And so they have, you know, basic resources. They know of PADV. They know how to sort of connect into the emergency shelter, but not quite to the level that you all know. And I think having the opportunity to have sort of an advocate type person that I could, you know, call and say, oh, hey, I like a human that I could connect this person with, to say, hey, this person can help you. And so being able to sort of, and I realize I work in the middle of the night as like a vampire, and so nobody's going to come in the middle of the night, but you know, but it's a lot of the times I'll see that like people, a lot of you know, dark and scary stuff happens at night. And so, it'd be really great to have a person to, you know, connect these people to kind of that warm handoff where they could, an expert that could help, you know, facilitate, do a patient-centered and very much a trauma-informed approach to care for that patient, and help connect to what services they want to connect to. And instead of trying, I just give them a bunch of handouts of phone numbers, you know, and our social workers help. But a lot of times it'd be really great to have a person that to, you know, like kind of that warm handoff would be great.
Lauren, that's great. I appreciate you saying that, because you know, we need to look at that. We need to look at about is that something we can do. We write lots and lots of grants to different foundations that focus on different things, and there are some foundations that focus on medical care. And so that's, you know, great. Thank you.
I would love to. I think that would be a wonderful opportunity to be able to, to be able to sort of bridge that little, and it's just a little jump. It's like 1 foot to the next stone, but like that one that can feel like forever for patients, you know. And I think they may, since they can't see it, they don't know, you know, it'd be if they had a person that helped, you know, or or some other avenue that it doesn't have to be a person. I guess in the COVID times, it's very hard. Like it could be, you know, some other way or some other way for people to connect would be really great.
This is an awesome conversation, and I brought that up because somebody in the comment section, Miss Monica Swan, asked.
Monica, hi.
Hey, Monica. Her question, and I'll leave it to both Lauren and Nancy, is how can we partner and do more for women in Georgia?
Yeah, and I mean, I think that's I guess the $1 million question. It'd be great to it would be great to break down the question in terms of how, like, there's so many different services I think we could provide. You know, I also serve as the forensic, I'm one of the sexual assault forensic examiner educators for our department. And so I see so much need in that area, so much need in intimate partner violence, child maltreatment. Like there's sort of cross-cutting violence initiatives, I think would be something that would absolutely benefit all involved. And you know, so I think tangibly, it'd be great to have some of these direct to service provider initiatives supported, but also prevention strategies. I really think primary prevention is where it's at now. And so, and a lot of the funders, especially from, CDC and other larger foundation groups, really want to look at primary prevention strategies to help prevent violence going forward. So I know that's a long-winded question, but I think there needs to be, cross-cutting violence initiatives and prevention support, and being able to support at all tiers of the public health pyramid would be great.
Yeah, I would absolutely agree. I think we did a strategic plan 3 years ago, and we interviewed stakeholders, we interviewed staff, and when we interviewed staff, we said, should we have more shelters? Should we have more beds?
Yeah.
Should that be our strategy? And they said, no, absolutely not. If we're doing that, we're failing in our mission to prevent the crime of intimate partner violence.
Yep.
They said, what we need to do is we need to do more outreach, we need to do more public policy work, and we need to find ways to partner more with other organizations to enhance the spread and the reach of the prevention work that we're doing. Absolutely agreed with, it is, they all fit together, the child abuse issue, the sexual assault issues. So we've had Georgia Center for Child Advocacy come in and do training with us about child abuse. We're doing a partnership right now with Mosaic, which is the sexual assault center in Gwinnett. It's funded through the Office of Violence Against Women, and we're focusing on children affected by domestic violence. So they're going to come in and sexual assault as well. So Mosaic's going to come in and do work with our kids in the shelter about good touch, bad touch. And then we are going to go out into the childcare centers and train childcare workers on how to recognize potentially domestic violence that's going on at home, and then how to get resources and help for that family. So I agree 100%. The way that we're most going to improve the services and the prevention is through really intentional partnerships.
Man, this is such an amazing conversation. I'm so excited. And I asked that question obviously purposefully because I want us to be able to get the ball rolling on some of this stuff. And let's be very intentional on how we push forward, because at the end of the day, we're serving the same group of people. And I think our missions are intertwined. So Lauren, I want to ask you a question on how do you currently support a survivor? So boom, like survivor walks in the door, bruises, and that's how they present. How do from that moment forward, how does the hospital jump in and begin to service that client from a medical standpoint and obviously a post standpoint?
Great. So, yeah, and that's a wonderful question. It's, I try to do the trainings for our residents for this to try to help our future emergency medicine docs kind of know how to appropriately treat the intimate partner violence patients. And so it's just like you mentioned, they come in and, first and foremost, we're medical providers. So we want to make sure that patient's stable. So we do a full medical screening exam, treat their pain, make sure they're comfortable, they know that they're safe. Actually, another kind of off a question you just asked, for the COVID times, we don't allow visitors currently. So now we actually used to focus on trying to, interview people in private so that they're not with whoever the person is that brought them in. And a lot of times that could have been the perpetrator, the person who's victimizing them. And so we still teach them, whenever this time passes, that, interviewing in private, getting a language interpreter is needed to make sure that we're addressing some of our non-English speaking patients. And just really asking them, some of the patients we see, they may not even have bruises. A lot of them they come to the ED frequently, kind of vague complaints, not really sure what's going on. And so sometimes it's not that obvious. And so we train our practitioners to, hey, when something doesn't seem right, or the patient's not, we're not sure why they're there really, we make sure to screen for intimate partner violence. So we have a lot of different ways. The classic way people ask is, do you feel safe at home? And we've talked about how problematic that is, especially in our population now. So we tend to actually say, ask really direct questions. So things like, have you ever been punched, kicked, hit, slapped, or otherwise harmed by anyone in the last year? If so, whom? And then ask if there's anyone from their prior relationships making them feel unsafe now. Like being really explicit and direct, because researchers have shown that that's actually the best way to sort of screen and ask, because then you really get real answers. So after you've identified that, we tell people to go ahead and make sure that you explicitly acknowledge to that patient, like, thank you so much for sharing that with me. They may have not shared this with anybody else in the before. So being able to make them feel comfortable and validate their sharing that with you, and then expressing empathy. We all know we're like kind and caring doctors, but making sure that you say, thank you so much, I'm here to help you, and thank you for sharing that with me. So then after that, it's really sort of figuring out the pattern of violence. If it's been something that's escalating in frequency, we look for IPV sort of lethal features. So things like if they've strangulation, abuse during pregnancy, escalating and escalating violence to the point where the patient's fearful for their life. Like those kinds of things really help us like put up our antennae that we need to really connect to this person. And so we don't just discharge people and say, okay, well, good luck. It's then sort of thinking through what options we have available for them. So we do connect with our social workers who have resources for your shelters. So emergency shelter placement tends to be our first thing we offer, and really try to help connect that person in to leaving that relationship and getting out of that toxic environment. There's a lot of different groups. I know there's a group that helps get their pets, and there's also, we have mental health and other sorts of treatment. If they have their own substance use disorders, we try to help with that. And then also, like you mentioned, a big important part of this is TPO filing. So getting that temporary protective order filed so that that patient can have the legal strength behind them in that situation. And so, so we work with the Atlanta Volunteer Lawyers Foundation to try to help connect some of our patients to legal services. So that's kind of the big picture approach,
Right.
And then, but a lot of times where, patients may or may not be comfortable with certain aspects of it. They may not feel comfortable right now, but we always let them know that we're here, 24 hours a day. The ED is always open. So if they're ever not safe, like they can always come back to us, mm-hmm. and we're here to help try to navigate with them. It's not the friendliest of places in the ED, but at least it's something. And so we're here to help them whenever they decide they want to kind of initiate one of those paths.
That's interesting.
That
Go
was
ahead, Nancy.
question. No, as you were talking, Lauren, I because that's always something when people say, well, how can I help someone? We always say, make sure that you do the interview with the person alone or intervention alone, and with no possibility of the perpetrator being present. And so I was thinking as you were talking, oh, well, with COVID, and they're having to come in by themselves, that makes it so much easier to do that.
Yeah, it takes that step out, definitely. And so that's always a source of anxiety for a lot of folks, even for some of our other victims, like trafficking and that sort of thing. Like it's been very much, it's been a blessing. And I mean, not really, but at least it's something that helps remove that variable. So we don't have to think about that when we're interviewing people.
So we actually just had that exact comment. Is Jennifer Thomas asked, how do we support victims at the hospital if their offender is with the victim? So let's imagine that we're either post-COVID or pre-COVID. What's that process like for supporting a survivor or victim if their abuser is bringing them to the hospital?
And so a lot of times, we used to have that like patient and family centered care where we'd have like a family member that was always, allowed with the patient at all times. And, sometimes there are moments when the patient is interviewed alone. So usually in the triage room, the initial triage that we do with all of our ED patients, the patient comes in on their own if they're able to walk, and they come into the triage room by themselves. And then our initial nurse that does the nurse first basically asks a bunch of questions. Even though I don't like the question, that do you feel safe at home question is the one that's in that triage question. So there's an opportunity for them to disclose there that, hey, maybe I'm not feeling safe right now. And then at that point we could, potentially intervene and have our providers come in and help figure out a plan to keep that patient safe right then. If we do happen to be, I have been in the room with them before. And so being able to say, hey, at this point we need to interview, interview Miss whoever, like in private, or Mr. It tends to be, I know, and I always err on that side of saying like female victim and male perpetrator, but a lot of times we see people of all shapes and sizes and all different relationship statuses, LGBTQ population, multicultural. So there's a lot of different variables. And so I think we just tend to normalize that we interview in private. And so I say, hey, like at this point, I want to be able to talk to this person about, about their health. I ask some questions. Can you please step out of the room? And so we tend to we do isolate our patients so that we can get answers, just like we do with our teenage patients from their parents. Mm-hmm. It's just something where we've been trained to sort of move that other person out of the room, especially when we're asking those kinds of questions.
And I so appreciate you talking about the, not making assumptions. That was going to be something that I asked you, because we work really hard to serve all communities. Obviously, actually no discrimination based on sexual orientation, gender, transgender, all of that. But I think often we do assume if a woman comes in, partner is male. And so, right, pre-COVID, post-COVID, the importance of not making those assumptions. And if a woman comes in with a woman, oh, she's my friend. Okay, it's fine. They can all be together. No, easily that could be the perpetrator as well. Or right, that is just basically,
it definitely muddles the water. Like sometimes when people are answering questions in front of their friends or family or whoever, it's just not really, they can't really say what they're really thinking or really express what they want. So we really try to build that like patient provider connection so that they feel empowered to answer however they honestly feel. And so so we find that helps in lots of different settings, and especially in domestic violence.
So actually, Miss Amy in the comment section had a question and a thought. Thank you so much for hosting this. Are there any cultural implications on the nature of domestic violence abuse and help-seeking behavior? So I'm assuming that the question is probably maybe for Nancy. And I'm going to try to frame it maybe so that it makes a little bit more sense to the group. I think she's more asking, do we see a difference in how culture affects how people, whether they seek help or not seek help? And Amy, if I didn't get that question right, please, you can scold me in the comment section or rephrase. But either one of you, just feel free to tackle that. Do you see a difference and from a cultural perspective on people seeking help for their abuse?
I think that's a great question. And what I want to say first is that we know that intimate partner violence occurs through every culture, through every race, through every economic status, through every educational level. So it's very, very important that we not try to stereotype and say, well, it's just these kind of people, and I still hear that. I still hear those kind of comments. With that said, I think culture can play a role in how people seek help. And let me talk about a couple of different ways. We obviously have a large immigrant community in the Atlanta area. And I think for the immigrant community, for the refugee community, for someone who's not documented, seeking help can be very, very difficult. I think, especially for non-documented people, the abuser often can use that, if the abuser is documented, to say, well, if you tell anybody, you're going to get deported, I'm going to have the kids, you'll never see your children again. So that cultural issue, and in certain cultures, I think asking for help can be more difficult, I think, or it can be considered culturally inappropriate. There's the good news is that there are organizations that are specifically focused on serving the Asian community, the Latino community, and Latinx community. I'm going to get my terminology right, but so that's great, and those are organizations that we partner with. So they may not have a shelter, but they can provide maybe that culturally appropriate support that's needed, while maybe we can provide the shelter, help with TPOs. They can help maybe with interpretation. Maybe we're both working with someone. In the African American community, again, I think there are cultural issues with the violence and killing that we've seen of Black people. That's a real issue for the Black community. And I think for Black victims of intimate partner violence, they have to weigh, if I call the police,
Yeah.
is it going to be protection, or is it going to be that I'm putting I don't want my perpetrator killed. I want the violence to end. But if I call the police and involve the police, am I putting this person at risk of being harmed or killed by the police? And so I may rather deal with the abuse than have that be the consequence.
Yeah.
I think there's, again, because of discrimination and racism towards the African American community, I think there's been a sense of, hey, we're not going to let those white folks know when we're having problems because they already give us such a hard time. So if I call the white establishment for help, then I'm putting my business out there, and they're just going to use that even more against me. So I think that can be a barrier. So I think we do well acknowledging and recognizing it happens everywhere, and we have to be ready to acknowledge and respond, and not assume, oh well, she's a white, educated, middle class woman with her master's degree. That does not mean, that she's not a victim as well, but that we do have to understand the cultural issues that exist for some folks, and include that in how we work with them.
Oh, it just warms my heart to see that you have, the culturally sensitive element of it, and making sure that our patients realize that there's no like one size fits all intervention for anybody, and so I find it so relieving to know that some of the resources that you all provide have that element to it, because it's something where I do worry about that. Like, some people just may not feel comfortable, accessing care if it's going to be something that's not sensitive to what their needs are. And so I loved hearing about, the different opportunities you have within, with the other partner groups that we have that help address those issues. And so that's great.
And Jeffrey, let me just say one more thing
go ahead.
about that, which is we predominantly serve African American women in our shelters. And we've talked about that. And we said, we know there's lots of white women that are being victimized by intimate partner violence. And is white women being less prevalent in our shelter also about racism? Is it also about saying, well, this as a white person shouldn't happen to me because it doesn't happen to white people, and I'm embarrassed and ashamed that I'm a white woman experiencing this, and maybe also I think it's all Black people that experience it, so it's going to be all Black people in the shelter, and maybe I don't feel comfortable being around all Black people. So I think those cultural, and that's a cultural issue.
Yeah, well.
So I think we need to look at it across all races and cultures, and that it's something, again, that in all races and cultures we struggle with racism, we struggle with prejudice, we struggle with assumptions, and we have to address it across gender, race, culture, all of that.
This has been an amazing conversation. I'm not going to even cut it short. I'm just going to let it keep going. Lauren, I was thinking when Nancy was thinking about answering the question, I was also thinking about, one of the things where you talked about in your previous answer of asking, of how do we ask people to leave, or how do we make sure that we're only seeing the victim in those scenarios? And I'm wondering, do you see those same, do you see a difference in the cultural issues as well of how they would present at the hospital when you get them in the room?
Yeah, I mean, it's interesting hearing, and when I was hearing Nancy speak about that, like who accesses shelter care, who goes, and it's interesting because I do see, like, we see, the same thing Nancy meant, all types of people come in with that, and it's not, and it's interesting to see that, the folks who actually go and initiate and access care are not necessarily the people I would have thought. It's a lot of times it depends, people who, and I hate to come down to it, but it's affluent, like people who have more money tend to have more resources, and so maybe would find, like when I ask, sometimes I say, do you have a safe place to go? What's the plan? And so I try to, our biggest thing is safe discharge planning, and so discussing with them a well thought out, really careful plan for that specific patient. And I'd say, a lot of those patients, that have, mom lives down the street that's really, or someone that he or she feels comfortable going to, it tends to be maybe people who have more, are potentially more affluent, or, and so that's a whole nother element and layer to the problem that I think, does play a role in how they're treated and how they access care. So and you know, I don't know, this shame, I'm surprised it'd be something, I'm not though, like that people feel shame or feel like they, you know, going to a shelter for this is something that people potentially feel that, and that's hard to hear. And so if there's a way to really help make that, you know, a little bit more palatable or more warm for people, so they feel like that's not such a embarrassing thing, or what, you know, whatever that term is. But I do find that to be disturbing, and you know, and so somehow to be able to bridge that gap for the patient so that it's something that feels less like losing control, because I think so much of this is being able to regain control in this lack of control situation. And so having something that really gives as much autonomy back to the patients as possible is really something that that I think would work. And yeah, so if there's a way to sort of build culturally sensitive and appropriate tailored care for patients would be my vote.
And Lauren, I think the shame issue, I do think that runs across every culture,
all cultures,
gender, sexual orientation, because that is a major part of the abuser's tactics.
Yeah, their control.
And the abuser's control is that it's not the abuser's fault that this violence is happening. It's the victim's fault. If you weren't so stupid, if you would shut up, if you would take better care of the children, if you were a decent cook, if you were nice, you know, on and on and on.
Yeah.
And there's that constant message. It's you, and along with being isolated from any other reality, that survivor believes it and begins to believe, oh my God, I am stupid, I am an idiot, I have brought this on myself. So then to go tell someone that they're experiencing this, well, basically there to them it's like, I've done all these terrible things and now this violence is happening to me. And the other thing that I'll say about that's why it's so important, and I know you know this, but just to folks listening, that response is, well, why don't you just leave? Well, what's wrong with you? Why do you put up with it? Because that's just more blaming and victimizing of somebody who's already been severely blamed and victimized. That instead that response needs to be, wow, I'm so sorry to hear that. You absolutely deserve to be safe. How can I be here for you at this point?
Absolutely.
Again, as I know you know, is giving that survivor that ability to start regaining that power and control over that survivor's life.
Very true. And we hope we express that as much as we can through our, you know, with our trainees and all of our learners, is being able to help them sort of realize all their options, and they're the one in control, and being able to whenever they're ready, and they know when they're ready, like we're always here for them. And so that's like the underlying message I always try to, with any survivor we speak to or encounter, is making sure that they know that no matter what, we're here for you. So and give them a bunch of different options, not like leave or stay home. It's not that simple. You know, there's all kinds of things we can do to help support them. And I definitely echo that. I completely agree. I think that's the thing survivors crave, is really being able to regain that independence and that autonomy.
So I think it's safe to say that Ashley wins question of the day so far.
Mm-hmm.
Yeah. Hey, so actually Jennifer Thomas asked, Lauren asked you a question.
Mm-hmm.
Are doctors mandated reporters for domestic violence? And is a doctor required to call the police if a victim discloses the abuse?
So interesting you asked that, because in certain states we are, but not, Georgia's not one of those states. So we're one where we, you know, from my understanding, the most recent iteration of legislation was that we're mandated inter-facility reporting. So we have to report to our social worker, technically is what that means. But in terms of mandated police reporting, no. So, because that can actually make that makes the conversation so much more nuanced, like having to say, hey, like, you know, before you tell me something, I may have to, you know, it's, or, you know, so I trained some of our providers when they are in states, I believe Texas, Kentucky, some shocking states, you know, there's some states that actually do have mandated police reporting for intimate partner violence or domestic violence. To be able to navigate that discussion is a little bit more layered. And so you have to say, hey, you know, depending on what we talk about, I may have to involve other people in this conversation. You know, so let me just, you know, premise with that. But of course, you know, not like I'm telling our providers to lie, like that's not something I would say, but it's something if that is fully not in line with what your patients wishes and and what they need, like trying to navigate the conversation in a way of like, here, if you're experiencing that, here's some options I talked to you about that. If you're really worried and you really do, we can involve, and let's and sort of just take over the conversation in a way, but let them sort of express their needs and wishes without them overtly disclosing that to you, is sometimes what I'd say. But it is a difficult, I definitely want to invite some other practitioners in those specific states where they have that to be able to help, because I haven't actually had to have that conversation with a patient yet. And so it'd be really great to involve a practitioner that has had to navigate that. But what I would say is trying it that way, to say it in a way where you're not making them disclose it. Because yeah, for child abuse, for elder abuse, we are mandated reporters. We make sure we always involve PD for those conversations. But yeah, occasionally for like TPO filing and that kind of thing, it's helpful to have police involved, from what I've understood from our legal partners. So yeah, so a lot of times we'd encourage it if they feel like if that's something they want, especially if they're in like those lethal IPV risk factors like we talked about. If I'm really concerned about their safety, I'd press for them or I'd urge, because I'd be worried about them. But again, I don't want to take that control. So it's a balance, the conversation's always a balance. And at the end of the day, it's the survivor's best interest, and what their wishes are is what we respect.
Right. I agree again, 100%. And frankly, I would not want to be in a state that mandated medical, because it's not a child. It's not an elderly person who may not be able to seek that help or to be protected without that. This is an adult person.
Agreed.
And again, you may disagree with the choices that they make, but they're an adult person and they have a right to make their own choices.
Agreed.
And frankly, I think if survivors knew that if they sought medical help, that person providing that medical help would have to report what happened to the police, they would be less likely to seek that medical help.
I completely agree.
Because for some survivors, they know, if I call the police, I will be killed. I've been told that 100 times, and I have no reason to believe that wouldn't happen. So I definitely need medical care for what's happened to me. I need some time to think about it and figure out next steps. But if getting medical care means the police are coming to my house,
yep,
I'm dead.
Yeah. And that's a realistic fear for some of our patients. And so I really feel completely agree with you. These aren't cognitively impaired people. Like, people have actual, I think implying that and being able to say, I have to take that from you, it's very traumatizing to people. And so I also agree, and I'm glad that we're not in a mandate. I think it's kind of the unintended consequences, like we mentioned. I think like the spirit behind it was, yes, let's help these people, but then you don't realize that there's a dark underbelly to that, and that's not something that I think is good for our patients. And so I agree with you, Nancy.
Man, I appreciate you. And actually, Jennifer totally agreed with y'all's assessment on being a mandated reporter as a doctor. Lauren, how do you deal with the stress? I mean, we talk. I mean, all of this we've talked about. COVID. We've talked about how that overlays with domestic violence. We talked about you losing a patient, you seeing a patient one week and then losing a patient the next week. How do you deal with the stress of all of that weighing on you every day? And Nancy, same question, because it's not uncommon for our staff to deal with the same kind of stuff. So both of you guys, same question.
Gosh, I don't know. I mean, it's interesting, because I'd have to say, like, on a personal note, I'm actually a very soft person. If you guys haven't noticed, like, I'm very sensitive, and I do kind of internalize a lot of what I see. And I remember when I was a trainee, I used to have a lot of difficulty, and this is like full personal, probably too much exposure here, but like, I used to be, I'd get like dizzy and get kind of Scarlett O'Hara and like pass, I don't know. I'd get very, I don't know. And I think at some point something clicked in my training where I realized, me responding in a negative or not responding well in these situations isn't helping the situation. Like, it's not, and in my mind, whether or not I'm there or not there, this is here. And so I feel like me being there and helping the situation as best I can and trying to impact the lives of patients really helped me kind of calm down when I'd see terrible things. And so I think I think I've taken that forward even now into my life as a mom and a partner. Like I am very appreciative for what I have. Every day, the things I see make me grateful for what I've got. So every day I have my life, I have my family, I've got my house, you know, so it makes me very grateful for what I have. And so sort of thinking from that lens of, and the work we do at the Injury Center, like doing our best to prevent it from every level. And then even when you can't, I'm there to catch you. So we're there to take care of you, even if we weren't able to prevent it from happening. And so I take it from that lens, and it helps me sort of sleep at night, you know, knowing that I'm doing what I can from each tier and each level to try to help prevent the injuries and things we're seeing coming in. But yeah, it can be stressful. You know, sometimes I go on runs. You know, everybody does the yoga or whatever, but you know, it's something that we all try our best to sort of unwind in our own ways. But I think that bigger view helps me deal with what we see. And I'm sure Nancy, like the things you guys see is, you know, like so much more of a personal view of it too, you know, so I'd love to hear about your strategies.
Yeah, I mean, very, very similar. I think you have to be really clear and accept what you can do and what you can't do. And you work really hard to do what what you can do, and let go of responsibility for what you can't do. At PADV, we work really hard. And one thing when I'm interviewed, people will say, well, what else do you want to know? And I say, or do you want to say? And I say, I want people to know that PADV is a really happy place, not in a naive, oh, the world is beautiful way, but we feel good about what we're doing. We know it's important work. We celebrate the successes. We ask people how they're doing. We try to have fun together. So I think those are all things that help you continue to do the work. Um, I agree, Lauren. I think you have to care, but you have to know how to care.
Yep.
I spent many years working at a program shelter for abused, abandoned, neglected youth, and man, talk about some hard stuff.
I can't imagine.
We saw some really hard stuff. And one day, a woman who had been working there not very long came into my office and said, you know, Nancy, I don't think I can do this job. We had a boy that had come in, his arm had been broken by his mother beating him with a broom. And she said, you know, when I heard it, I just went into my office and cried, and I just don't think I can do it. And I said, you know what, when you don't want to cry, when you hear that, that's when you need to stop.
Yeah, there's something wrong with you.
Now, for you to go out and sob in front of that boy, that's not doing any good whatsoever. You need to be strong. You need to be able to hear it. You need to be able to tell him that you care about him. But you need to hurt inside that these things are done to children, because if it doesn't hurt you, then you don't have the heart and the passion to do this work.
Gosh, and that's so much what we see too. Like it's the same thing, like and being able to still be there and feel it, but not go to pieces in front of people is it's critical. And I think that's something that we all work on every day.
So you know what, guys, the conversation's been good, and I don't want to be the stopper of the conversation, because I feel like, you know, the comment section is going to be mad at me here. we have been going for
go all day though, Jeff.
No, we can't go all day. We cannot go all day.
I don't know about you. I could go all day. No, I'm just kidding.
Well, I mean, I talk too much, so I can go all day.
No, me too.
But so I really have one more question. It's the same question for each one of you guys, very similar. And unless the comment section has another question, then I'll throw that in as well. But my last question for both of you guys is, how do we bridge the gap between the ER, the community, organizations and organizations like PADV?
Well, I think we're doing it. I think it's what we're doing today. I think it's looking at how we do the same work, but have different pieces of it. I think it's how we can even more integrate and share our pieces and our knowledge, and in supporting and providing services. You know, there's probably interlap between the clients that we serve and the patients that Emory serves, but there's also probably a big area where it's not overlap. So how do we bring PADV's resources and knowledge and services to the hospital patients that aren't going to reach out to us otherwise? And how do we ensure that the clients we serve really know about and connect with the important medical services and mental health services as well that exist in our community?
And I wholeheartedly agree with that. I think being able to connect what we do, and that's why I'm so thrilled to have this conversation today. I think this is a very important step. Even though I know we've functioned together in the past, it's just great to see this level of engagement, you know, and to kind of build off what Nancy had mentioned. I think being able to sort of think of it from different lenses as well, like how we have we've mentioned that great opportunity where we may pursue something together to try to help, you know, so, and then also, you know, there's other ways, especially, you know, our injury center supports, you know, research and education and outreach. So there's lots of different ways that we can sort of address this issue and be able to help, you know, bridge the gap from the tertiary patient encounter up to earlier prevention strategies. And so being able to sort of think through it from that lens and then potentially partner on multiple tiers. And so I'm just thrilled to have had this conversation. And I do, as much as it's, you know, I love that we're on Zoom. I can't wait to at some point meet you all in person. Yes. And then also go see, you know, just see your facilities, see, you know, meet, do some focus groups. Like, we're game. Yeah, we absolutely we'll dive in with that. So
awesome. And you know, one thing that I took from this conversation, and actually, Lauren, I lied. I do have one more question for you.
Oh,
but
great,
it's one question I ask everybody. But the one thing I took from this is it seems like there's a lot of opportunity between us and iPrice just to really dive deeper into some research as well, so that we can really get to the heart of the cause and the heart of how we really fix this going forward. So it's not an anecdotal anymore. It's
agreed.
Here are some hard facts that we can bring to the table and leverage. Really leverage not only the community, but also leverage funders to say, hey, if you give us X, we can do Y, right? And so Lauren, last question for you is let's assume we have a group of people watching right now. They're all survivors, or they're all living in a home with domestic violence being present. What do you say to that? What do you say to that person, or what do you say to those people?
You know, and first off, it's thank you for coming and being here. I think that's the biggest step, is being able to know that there's people out here supporting you, you know, and I don't know that people feel that way. They feel completely isolated and alone. And so what I would say to those survivors is, we're here for you. There's lots and lots of options. There's not a binary leave him or stay. There's a lot of options, and something tailored toward that particular survivor's needs and interests. And so I think that's the bottom line thing I would say, is that we're here for you, especially, you know, clinically. I'm there, you know, we're there 24/7. So, you know, so if there's ever, and then as are you all, you know, and so I think being able to have people aware of that and know that they're not alone is critical and important, an important first step. So yeah, so that would be my answer.
Thank you. Awesome answer. And the only reason I ask all our guests, and Nancy probably gets that question from me way too much. So I just want to thank you both. Y'all were both amazing. I do want to make sure I do some housekeeping here, and let everybody know. Make sure you go and visit the iPrice website. There's a lot of great content there. Just share my screen. It's iprice.emory.edu. There's, like I said, there's a lot of great information there. About the Injury Prevention Center, about ways to get involved, about what they're doing in the community. So I just encourage you to take a moment today. I know we've been on for about an hour. And so I do want to make sure that we plug Emory's Injury Prevention and Research Center, because this is they're doing amazing work, and we want to make sure that the community is fully aware of all the great work that they're doing. And then also I want to make sure that we do let the community know how do we support Partnership Against Domestic Violence. And our website is super simple, at PADV.org. You can go there, and all the different ways that you can support our organization, whether it's if you want to donate a financial contribution, we'd love to have your support in that arena. And you can just click the little donate button there on the side. But if you want to support us from an in-kind perspective, right, you can support us with in-kind donations of new clothing or new shoes for kids, or just things in general that kids need to have to go back to school. And obviously, if you want to volunteer, we're doing that all virtually right now, but you can obviously go through that process of volunteering on our website. if you are a survivor or if you're currently living within a home where domestic violence is present, my encouragement is always going to be to call our crisis line, whether you're ready to leave or you're not. Pick up the phone 24 hours a day, 404-873-1766, 404-873-1766. And follow us on all our social channels at padvatlanta.org. Again, I just want to say thank you to iPrice for jumping in. This has been an amazing conversation. Like it has not felt like an hour at all.
Yeah, it was a ton of fun.
It was a ton of fun. And so I just want the community to know about you guys and to support you guys because you are doing amazing work. And if you need Lauren, you can go to the iPrice website. I'm sure she loves to talk as long as she's not on one of her sleeping days. Yeah. So, like bring her on and let's really begin to have a broader conversation around injury prevention because it's important. And I think there is some data, there is some research that we need to do as a group, but I think we can really, really nail down how do we prevent injuries and how do we really get to prevention of domestic violence. So thank you, Lauren. Thank you, Nancy. Thank you all for watching with us today. I think we're doing another one of these on Friday about teen dating violence and Teen Summit. So come back and join us then. Friday, I think at 10:30 as well. And so this is going to be another fun conversation. So we appreciate you guys for watching with us today. Y'all have an awesome day. Bye.
Thank you so much.
Thank you. Thank you.